thank you everybody for taking their time to join us tonight. As Kelly said, just kind of a brief intro. I've been in the community for about 4 years, and I just joined MultiCare this summer. My practice really revolves around kind of robotic surgery, kidney stones, as well as kind of BPH and minimally invasive BPH surgeries. I really enjoy treating BPH in men. A lot of what we do is cancer related, and it's unfortunately people have to go through surgery. But the neat thing about BPH is a lot of the procedures are elective, and I can really improve someone's quality of life. So something I really enjoy doing here locally. Next slide. So just kind of as some background, just a brief overview. So the prostate gland is part of the reproductive system, and it's about the walnut size. It sits right below the bladder, and it produces a protein called PSA, which I'm sure many of you have heard about, or prostate-specific antigen. And that protein is actually really important in reproduction, in that it actually helps to kind of liquefy the semen and aids with fertilization. So it's helpful in our reproductive years, but then unfortunately later in life just causes us problems. So next slide. So there are kind of three large categories that can affect the prostate. There's prostatitis, there's enlarged prostate, which we'll focus on today, and then prostate cancer. Prostatitis is often caused by an infection in the prostate, and it can be kind of an acute bacterial infection, or it can be some kind of chronic inflammation as well. Prostate cancer, as a lot of men are familiar with, is one of the most common cancers in men. And sometimes is slow growing, but sometimes can be more aggressive and cause problems. And so it's something that we always need to keep an eye on. And then again, the focus today is going to be enlarged prostate, or BPH, and that just refers to enlargement of the prostate gland. Next slide. So this is a nice chart. It's kind of depicting the prostate size as we age. And we see that there's a couple phases. So obviously when we're an infant and through childhood, our prostate begins to grow, and it kind of peaks around our early 20s, and then it plateaus. It really doesn't change much in size. And then as we enter kind of middle age, our mid to late 40s, it starts to grow again and continues to grow throughout the rest of our life. And that's why many older men experience symptoms related to enlarged prostate. So again, this is another chart just depicting the incidence of enlarged prostate. As you can see on the top line here, it affects 42 million men in the United States each year. So it's very, very prevalent. And then the bottom part here just depicts the age and the incidence of BPH. So we can see at age 50, approximately 60% of men experience symptoms of BPH. Age 60, 70%, age 70, 80%. And then by age 80, the overwhelming majority of men do have some symptoms of enlarged prostate. Next slide. Okay, just more on the prostate overview. Next slide. So what is BPH? BPH stands for benign prostatic hyperplasia, and it's a clinical term that urologists and other physicians commonly refer to. It's important to understand that when we're talking about BPH, it's non-cancerous enlargement of the prostate gland. So non-cancerous is very important. I do see a fair number of patients that think that if they have an enlarged prostate, that also means they might have prostate cancer. That's not true. It's really a completely separate process compared to prostate cancer. Another common question we get is that, oh, my PSA is elevated. Do I have prostate cancer? And it's important to understand that the PSA is a very generic test that we use to screen for prostate cancer. But also another common cause of elevated PSA is prostate enlargement. And so that's really where a lot of our expertise comes in as urologists, is figuring out, is this a benign process, or is this potentially a cancerous process that we need to look further at?
I apologize, the slides are running a little bit slow. If you guys could turn off your camera, if not necessary, that would be great. It might help us run a little bit quicker.
Everybody's so excited to be here, so. Okay, so normal versus enlarged prostate, and this is really kind of diving into some of the nuances of the anatomy and what happens. So the prostate basically is kind of the shape of a donut, and as it enlarges, it closes off that kind of inner hole of the donut. And so it causes pressure on the urethra and actually causes a mechanical obstruction. So if you look at these two pictures, on the left is the normal prostate anatomy, and then on the right is going to be of an enlarged prostate. On the left, if you look at the bladder wall, it's relatively thin, and then if you look internally of the bladder, it's very, very smooth. And then just below the bladder, you have that walnut-shaped gland, which is the prostate. You can look and see where it's pointing to the urethra there. It's nice and open. And so urine is able to pass easily through the bladder, out the prostate, out the urethra. On the right side is showing, on the right side is showing an enlarged prostate. And because of it's enlarged and causing a blockage, the bladder wall has to work harder. And the bladder wall is a muscle, and much like your biceps, when you do more curls, the muscle enlarges. The same thing happens with the bladder wall. So a lot of guys will have imaging done for another reason, and they say, oh, my bladder wall is thickened. That's typically a sign of the bladder working hard to help push the urine through the prostate that's blocking them. If you also look at the inside of the bladder on this picture here, we see that it kind of has a spider-webbed appearance, and that's again another sign that the bladder is working hard and something we can see during a workup. Next slide. So what are the symptoms of BPH? There's really a whole range of symptoms. It can be frequent urination. So, having to go every hour or two. That can happen during the day. That can happen at night. Some men get the sudden urge to urinate. Sometimes it's so strong that they can't hold it. Sometimes men have some weak stream. Sometimes men have difficulty emptying their urine. A lot of guys will say, hey, my urine flow is very weak. It's difficult to hit the back of the toilet. And in the more severe situations, sometimes men are actually unable to urinate. And that's an emergency. And again, that's because the prostate's completely blocked them off. So next slide. Okay, so this is actually a really important slide, and I'd say this is kind of a paradigm shift in urology. So historically, we just used to see men in the office, and if they were bothered by their symptoms, we would put them on some medications, and occasionally intervene. What we've realized is that that's a very reactive situation. And now what we know is that if prolonged BPH is not treated up front, it can actually lead to bladder damage, and sometimes this is permanent. So now we're recognizing as urologists, it's better to kind of get ahead of this and sometimes intervene on the earlier side of things. And a common analogy is, if anybody goes to their primary care doctor, they're going to make sure that their blood pressure is controlled. They're going to make sure that their cholesterol is controlled, their diabetes are controlled, because we know those are all risk factors that put strain on the heart and heart failure, and so nobody wants to have heart failure. The same thing, urologists, we want to try to prevent bladder failure. And if you look at this slide here, if you look to the far left, and this is by the way, this is a scope called a cystoscope looking inside the bladder. We see that the bladder is very smooth, and it's kind of got this nice pink color. The middle picture here is showing some signs that the bladder is being stressed out, and that it's starting to show some signs of damage. And you can see how it's kind of got that cobweb appearance. On the far right, you see a very heavy cobweb appearance, and this is a bladder that's got permanent damage. And the issue with that is if the damage is so severe, it can actually lead to the bladder not working, and men end up with urinary retention. Men are not able to urinate and have to have a catheter. So it can be quite problematic. So again, we're really trying to focus on preventing bladders from coming to that permanently damaged stage. Next slide. So how is BPH diagnosed? Typically, when we see men in the office, the first thing we do is we ask a medical history, and particularly we focus on what symptoms are you having. We also most urologists are using a survey. It's called the IPSS, stands for International Prostate Symptom Score. This is an objective survey that lets us kind of drill down to really how bothered and how symptomatic men are from their prostate issues. What we've learned is, if you ask a guy, hey, how you peeing? They say fine. And fine is it's variable, and so this gives us more detail. It really helps us figure out how best we can help our patients. Um, Down below, we do have some additional testing we can do. And this isn't for every patient. This is really part of our job, is to figure out what tests we need to run to collect the adequate data so that we can make a best decision for you and how to best approach treatment. A couple of the potential studies we can use is a UroFlow. Basically, we have you pee into a cylinder and it measures the velocity of your flow. We can do a digital rectal exam, which is helpful in assessing the size of the prostate. We can do a bladder scan. And really what we're doing is looking to see how well are you emptying your bladder. In a little more detail, we can actually do pressure flow studies, so we can actually look to see how hard your bladder is working to generate that flow. And then finally, we can do a scope in the bladder. And the scope in the bladder is really important in being able to evaluate your bladder health. And going back to that last slide, seeing does your bladder have those changes where there's potentially some permanent damage. And then finally, we can do an ultrasound as well to help us. So, again, these are instruments that we have. They're not always indicated, but they can be very helpful in getting some objective data to formulate a care plan moving forward. Next slide. So this is the IPSS, which is the survey that I just referenced. Basically on the left are all the symptoms that are related to enlarged prostate, and you will sign a score for that. And then we kind of lump them into three different categories. There's mild, moderate, and severe symptoms. Typically mild, can be monitored or managed with some common prostate medications. But we know that kind of when you get to more moderate and severe, these patients tend to do better with potentially an earlier procedure to intervene. And then we also have a quality of life score, which is really important because at the end of the day, we also want to know how much this is affecting you. Kind of gives us a sense of how we can help you most. So next slide. Okay, treatment options. So this is where my partner, Dr. Greene, is going to take over. He's got great experience. He's going to go through all the options out there for you guys. So thank you.
Hey, thanks, Dr. Murray. Just wanted to start by thanking you all for coming and joining us this evening, taking time out of your day and evening to spend a few moments with us. I hope it's informative. I hope we have a chance to have a better understanding of the prostate, as Dr. Murray did a great job kind of explaining what the prostate is and BPH, and also really honing in that bladder health has kind of been, unfortunately, probably ignored too long, for far too long, and understanding that bladder health is critically important to what we do. So really just thank you all for attending tonight. I've been back in the Washington community here in Olympia for the past 3.5 years or so. I did my residency up the road at the Army Hospital, but the Army made me move away for a few years. But I'm back now and enjoy being in the area and enjoy taking care of patients here in the community. As we transition now to talking about treatment options for BPH, this is kind of a busy slide, but it does kind of give a nice summary of the various treatment options that are available. And I think it's important to understand that there is no one size fits all. Everybody can be on a different stage or a different part of the spectrum of the disease process, and there's different treatment options available for everybody. At the left of the left part of the slide here, it talks more about the less invasive options. As we move further right, the invasiveness of the options increases. Under the least invasive options, there are things you can do on your own at home. We kind of lump those under behavioral modifications, things like dietary changes. Some foods and liquids that we consume can be very irritating to our urinary system. Specific or common things are things like caffeine, alcohol, spicy food, artificial sugars, and things like that. Those can be modified. Some people can do quite well with bladder training. It's kind of that idea of allowing the strong urge to pee to stop by stopping and strengthening your pelvic floor muscles through the Kegel exercises. Many of you with partners may know that Kegel exercises are a common thing done, but can be very helpful. And some people are just either for medical reasons or are not ready to proceed with any treatment and they are okay with their symptoms, then that's fine too. Common first-line therapies include things like medications. Flomax is an extremely common drug that many men take to help them pee better, faster, easier. And some folks are happy taking that, but some do not respond to medications well, have side effects, or are not interested in taking more and more pills to help them pee better. Unfortunately, it's not infrequent that people end up taking 2 or 3 different medications just to help with urinary symptoms. So there are other options. Again, under these less invasive treatment options, you may have heard about water vapor therapy or Resume, or permanent implants, which is the UroLift, which we'll be talking about here a little bit more in more detail. Finally, on the right of the page, the surgical procedures. A TURP or Roto-Rooter has been out for decades. It's still a very effective surgery. It does involve cutting and removing tissue, which can have some side effects down the road. Laser therapy is a kind of another way essentially of doing a TURP, but it uses a laser to do that. And finally, some men require removal of all or part of the prostate, again, kind of depending on prostate size. So we're going to transition now to talking more specifically about the UroLift system. And this next page here kind of gives a nice summary of the procedure, what it entails, and how it's performed. As Dr. Murray previously described, the prostate sits right below the bladder. And as the prostate grows, it grows not only outward, but it's that central mechanical obstruction of the urethra by that central growth that causes all of our problems. The procedure is done by inserting, thankfully, while you're typically asleep under some form of anesthesia, an instrument into the penis. The instrument compresses the prostate tissue on either side, and implants, permanent implants, are placed within the prostate to keep that compression, to resolve or relieve the mechanical obstruction in the prostate, to open up the urethra and improve your ability to urinate. It's really been quite a revolutionary change in the less invasive or minimally invasive treatment options for BPH, as it's typically performed in 10 to 15 minutes as an outpatient procedure with quick improvement in urinary symptoms. Next slide. The implants that, again, are permanent are very small. You can see here, obviously, this is not the actual size, but you understand that it's much smaller than a dime. It consists of 3 components. There's a nitinol capsular tab. Nitinol is a heat-sensitive metal, so it's soft and not irritating in any way. The permanent suture material is used to compress or squeeze those 2 end pieces together to, again, move or manipulate the tissue out of the way in the prostate. I kind of liken it to opening the curtains on a window. You're just pushing tissue out of the way. There's no cutting, no burning, anything like that. Finally, on the inside is a stainless steel end piece that does get covered by the normal lining of the urethra over a short period of time. Next slide. This is a quick video that we're going to watch that just, again, explains the procedure and how it's performed, just to give a quick summary here.
The UroLift System is a new minimally invasive technology designed to relieve urinary symptoms and improve quality of life for men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH. As the prostate becomes enlarged due to BPH, it presses on the urethra from the outside and causes it to become blocked. Relieving obstruction of the prostate is clinically proven to improve urinary symptoms in men with BPH. Under endoscopic guidance, the UroLift system is gently placed into the urethra to the area blocked by the enlarged prostate and moves the obstructing prostate tissue out of the way, thus opening the urethra. Through a fine 19-gauge needle, an implant is deployed that holds the prostate in this new, less obstructed shape. The UroLift system is designed to offer a new way to relieve prostatic obstruction without cutting, heating, or removal of tissue. Next, the same technique is applied to the other side of the prostate. Because the outer capsule of the prostate is typically firm, it holds the urethra open. The number of implants required depends on the size of the prostate and the degree of obstruction. Typically, 4 to 5 implants are used. Before applying the UroLift system, the urethra is blocked due to an enlarged prostate pressing on it from the outside. After applying the UroLift system, the prostate lobes are pushed aside, leaving an open urethra.
So a nice simple animation, again, explaining how the procedure is performed. Obviously, it's an animation. Those are not real live shots or videos, but it is simply manipulating or moving the tissue out of the way to open the urethra to improve your ability to urinate. And again, it's generally very quick, easily procedure performed in an outpatient setting. Next slide. So what to expect during the procedure? Again, it can be done in the office setting. However, we find patients generally prefer the experience while done in the hospital with some sedation of some type. So while you're asleep under anesthesia, the instrument is inserted into the penis, where you can see on this picture on the left side, the obstructive appearance of the prostate. Again, this is directly from the view that I would see while performing the surgery. The prostate tissue is completely obstructive and there is essentially no channel or a very small channel to pee through. After the implants are deployed and the curtains, so to speak, are opened on the prostate, there's a wide open urethral channel to, again, improve your ability to urinate. Next slide. After the procedure, most men do not require a catheter. I think that's a big advantage to something like this. I do tell patients there is a risk of needing a short-term temporary urinary catheter. Typically, that's at most 15% risk, which is much lower than a lot of other procedures. So generally no catheter. Blood in the urine is very common. It does fluctuate quite a bit. It can be just very mild and light. Other times it can be or appear quite red. Generally, as long as you're urinating, it is not a problem. Some pain is expected. Probably the most common symptom people will experience is temporary. And when I say temporary, I think usually about a week or less of the sensation that you need to pee frequently or urgently. That is typically, again, temporary and usually resolves after a week or less. And frequently you go home with medications to help kind of control a lot of these symptoms. Typically, there are no long-term restrictions on activity or heavy lifting, just all short-term. Many symptoms, specifically flow and emptying, generally can improve within the first 2 weeks. However, some symptoms, specifically the frequent need to urinate, urgent need to urinate, nighttime urination, can be slower to recover. And that's, again, likely due to some bladder damage or some concern about bladder health. I think a lot of people ask, how long will this last? The prostate is, unfortunately, as Dr. Murray showed in that slide, it's a recurring, ongoing problem as the prostate continues to grow throughout our lives, and nothing in the prostate lasts forever. There's strong data to suggest that at least 5 years is a reasonable expected outcome. I think 5 to 7 years is pretty common. Obviously, that can vary patient to patient. The other nice part about this is the term we use is it doesn't burn any bridges, meaning that if this is successful for 5 years and you want to repeat it, it can be done. If you would like something else done later, something else can be done. It doesn't impact or affect any other treatment in the future. Next slide. So this is kind of, again, a quick table. It's a little busy that just compares UroLift to other treatment options as far as what to expect and outcomes. I think the obvious thing here is The UroLift doesn't have any risk of sexual side effects, specifically trouble with erections. If you have that issue already, it's not going to make it better, but it won't make it worse. It will not cause any trouble with ejaculation, and there is no risk for urinary incontinence. The TURP, the gold standard, is, again, still a very effective operation, but there are risks for incontinence and erection problems, as well as ejaculatory dysfunction that are, thankfully, other than the ejaculatory dysfunction, are low risks. They're not zero, whereas the UroLift has none of those risks. So it's really a rapid improvement in urinary symptoms for most men with very little or low risk. Next slide. UroLift is covered by all insurance carriers, Medicare, commercial, private, all sorts of different carrier options. Obviously, there can be some copay or deductible involved, but it is covered by all major insurance companies. This is just, one example of a testimonial where basically, through a very minimally invasive, quick procedure, he was able to significantly improve his quality of life. And again, I think going back to bladder health, anything we can do to preserve and prolong and improve bladder health is just in our best interest as guys. I think, unfortunately, Dr. Murray and I have seen gentlemen whose BPH has progressed so significantly that they're catheter dependent. Once the bladder fails, we unfortunately cannot fix that surgically. So that's why it's important to at least talk about these sorts of issues. Next slide. So what are the next steps? Well, come see us is the bottom line. And we can certainly work you through the process. And on the next slide, it'll kind of really hone in on what you could expect at your first visit. If you want to go to the next slide. When you first come to see us, starting at the top here, you'll complete a symptom score. Again, it's a paper document that, as Dr. Murray described, gives us a good, accurate assessment and understanding of your symptoms, what is bothering you, and more importantly, how specifically and how impactful it is in your quality of life. We can talk about your PSA and medications. Frequently, we'll talk about other testing, things like cystoscopy or a camera in the bladder. I know it sounds bad. Thankfully, it is very quick and most men tolerate it very well, but it does allow us both, because we do have a monitor you can participate with, allow us to get a good assessment of your bladder health. Frequently, we'll do things like ultrasounds or some other imaging study to determine how large your prostate is. And we do have a new bladder pressure cuff called a UroCuff that allows us to understand, again, how hard your bladder is working to pee. If your bladder is working hard and you're hardly peeing, that's a sign for impending bladder failure, which is really concerning. Once we have all the information together, we sit down with you and a partner or family member or anybody else and discuss treatment options available to you and come up with a shared decision-making treatment plan. I think Dr. Murray and I both strongly believe that we're here together to help, to have a conversation and come up with a treatment plan that works and is effective for you as the individual patient. And I think with that, we can open it up for questions.